It can be embarrassing and it's sure to deal with, but there are steps to avoid or treat urinary incontinence problems. Tonight, on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We'll visit about the causes of urinary incontinence. What can be done to help prevent it? And if you do have it, what can be done to treat it? But let's first take a look at this week's Prairie Doc Quiz question. Choose the best answers. When urine leaks with a cough or a sneeze, this is called A, urge, or B, stress incontinence. When the sudden need to urinate is so strong that the individual doesn't make it to the bathroom on time, this is called A, urge, or B, stress incontinence. Choose the best answer for each situation. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answers in. We answer your medical questions the whole hour about urinary incontinence as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. So joining us tonight is Dr. Mathew Barker, Fellow of the American Congress of Obstetricians and Gynecologists, works at Avera Women's Health in Sioux Falls. Thank you for joining us, man.
Well, thanks for having me, Dr. Holm. Appreciate it.
I was thinking the last time we had you, we did this show on Lake Ponce.
Beautiful Lake Ponce. It was probably about 40 degrees warmer.
Oh, it was.
Beautiful
we were
day.
sweating our head off.
I wasn't in a tie that day.
No, none of us were. So you are an expert in urogynecology, or maybe you're a better call it an expert in female pelvic musculature problems, or what would you say?
So what I'm board certified in is called female pelvic medicine and reconstructive surgery. So that focuses on pelvic floor disorders of women, meaning related to how the bowel and the bladder and the organs are supported in women. And another terminology that most people associate with what I do is called urogynecology.
Right. So, but that implies that it's only the urine. And you, as we discussed before this, you also deal with constipation problems or diarrhea problems or control problems.
Well, the pelvic floor refers to all the muscles that support the functions in women's bodies that deal with urinating, reproduction, and bowel movements or defecation. And so a lot happens in a very concentrated area. And what urogynecology hopes to do is kind of bridge all those things and really take a comprehensive look at women who have disorders of the pelvic floor.
So what, you're a young guy, you're from Sioux Falls, your dad was Jack Barker, the gastroenterologist, and you went to med school or pre-med in college and so on and so forth, South Dakota. What brought you to go into this field?
For me, seeing my dad as one of the first gastroenterologists and watching his career, I always looked up to him, still do. And I like gastroenterology, I like functional medicine, and my mom was also very involved in women's health issues, and so that kind of led me to OBGYN, and I did a 4-year OBGYN residency, and then I really gravitated towards issues affecting women of pelvic floor disorders, incontinence, and I thought this was going to be a great need, especially in a state like South Dakota, where I could come back and bring something to. I enjoyed older patients, I enjoyed the surgery, a lot of it's vaginal surgery, and that unique focus, and that kind of led me to do a 3-year fellowship in female pelvic medicine and reconstructive surgery. And we were talking to some young students earlier tonight,
right,
who are want to go and pursue a career in medicine. and I wanted to move on and tell them, you know, you should find something that you can bring unique back to your state. I'm very indebted to the medical school in our state, and I thought this is something that I could add to the medical community.
You know, I love you saying that, and of course I am too. I mean, you think about opportunity that was brought to both of us because of our medical school in this state. Because South Dakota kids, hard to get them into other places. I mean, you've got to be super duper duper to get into other places, and but this is a super duper school.
Well, we have a great school. We just had the match, or where our medical students enter into their residencies, and they all got great spots. They're all going to do wonderful things. We should be very proud of our medical school that people are looking to emulate what we do here in South Dakota. So now the students that are trained here, they're young and they're bright. Different programs throughout the country are seeking them out.
They're realizing what we have here.
Definitely.
You know, something about the work ethic of South Dakotan kids.
100%.
You know, when I was in med school, we had to go the second 2 years somewhere else. And so we were always looking at, maybe we're not going to get another place. Boy, Emory in Atlanta, you know, a pretty hot medical school, said, we love South Dakota students. And I mean, they took a lot for a good long while until we've had now the four-year school.
Yeah, and I think now you're seeing where people are, because of the four-year medical school, Sioux Falls is transforming into a really strong medical community that now people from all over the area, even when I go to different conferences, they know about South Dakota. They know what we're achieving here and how we're expanding our healthcare facilities.
I think about when they were trying to get the four-year medical school, and they said this was going to be an economic good thing to do for South Dakota. Duh. It was a fabulous thing for South Dakota.
I agree.
And for us. So what is the most common problem that you see?
Well, can I give away the quiz, or when am I allowed to say anything? I'll wait, but the most common issue I see is urinary incontinence in women. That is hands down the majority of what I see on a day in and day out issue that are facing women. And it is so common.
What percentage of women have?
Over half of women will have urinary incontinence in their lifetime.
In their lifetime?
In their lifetime.
But does it happen most of the time when they're older?
And it happens a lot of times after childbirth with activity. And then as women age, they risk worsening urinary urgency or frequency and incontinence. And I think what you're seeing now, especially as people are aging, is the most common reason people are going into nursing homes is because of incontinence and the care for that. And so there are a lot of things we'll talk about hopefully tonight what we can do to help people out, but managing and controlling and oftentimes curing people of incontinence is definitely something we can do now that can really help people and prevent people from losing their independence.
So it amazes me that you would say that people would actually have to go to the nursing home because they have urinary incontinence. Wow. Yeah. So one of the things that I've looked at, I mean, do you ever help a guy with urinary incontinence?
No, so my specialty is all for urinary incontinence in women, but there are urologists that are available to help people with urinary issues. And in men, it's typically related to the prostate and either complications from an enlarged prostate or even complications after prostate surgery.
Okay. So so is it as common in men as it is in women?
What's interesting, the majority of incontinence is occurring mainly in women, but as both men and women age, the incidence of urgency and urge incontinence actually start to equal each other when they get into becoming octogenarians or in their 80s and 90s. You're seeing both men and women are afflicted by urinary incontinence, and it's debilitating for both of them.
Okay. So let's spend a little time talking about the most important tool that women would have in helping them with incontinence in general.
Yeah, and I think that gets back to what a urogynecologist does or what female pelvic medicine is about, and that has to do with the bowl of muscles that support the pelvic floor.
The bowl?
Yeah, so it's basically you have the shape of a bony pelvis, has an opening.
Yeah.
And those muscles then support both the bladder and the uterus or the womb as well as the rectum. And those muscles can be stretched during parturition or when a woman delivers a baby.
Parturition meaning having a baby.
Having a kid. And that's the most common problem, but also the age and the weakening of those muscles are the things that happen that often lead women to develop urinary issues, whether that's urgency or frequency or urinary incontinence. So having a good pelvic floor strength and tone is key to maintaining continence.
So, I mean, I've heard it, and you know, I think 20 years ago, well, I mean, I started trying to encourage people to do the Kegel exercises. I don't know that I ever got anybody to do it. I mean, I encouraged it, I had a handout, I walked them through it, and when they would come back, I would say, well, have you tried this? Well, to be honest with you, no. Now, tell me we can do, there's a better way of doing it.
So when someone refers to a Kegel exercise,
Kegel.
All right, and he was a physician in California.
Fred Kegel.
Yes, and in fact, one of my first patients I had when I was in South Dakota had been living in California and had seen him and
Actually seen the guy.
Seen the guy and been taught Kegel exercises from him, but it's to strengthen those muscles, contract those muscles, because those muscles can be isolated, just like you can isolate your bicep when you contract your arm, all right? Yeah. And normally those muscles have a sense of tone, meaning that they're constantly kind of contracted, and when an exertion occurs, such as a sneeze or a cough, those muscles contract to help block the urethra from opening so urine doesn't leak out.
Right.
And the idea of Kegel exercises is increasing that tone, increasing in the strength of those muscles. The problem is over 30% of women cannot isolate those muscles on their own. So if your patient that you saw and you said, all right, you need to go here's your Kegel exercises and go do those and come back and tell me how you did, if they are not adequately assessed with a pelvic exam to test those muscles to see that they actually isolate them, they might not be doing it correctly, and all the Kegel exercises they feel like or think they're doing, they probably are not.
Oh, wow. And before we go to this roll-in, I was thinking about the fact that you said 50%, I've read 30%, but I mean, a lot of women have incontinence. I mean, a ton of people. How many of those people have ever told anybody that they have a pad in their pants and that they have a leaky problem?
It has a stigma, it is embarrassing, and
it shouldn't be.
It shouldn't be, but it is not a common thing. It's not a part of aging. This is not normal. Having urinary leakage or incontinence is not normal. All right? You can get help, but women are embarrassed, and men too, are often embarrassed to tell their provider. But what's even important, meaning their healthcare professional that they're seeing, but what's important is our healthcare professionals aren't asking about it. They might ask if you used a seatbelt when you drove in there, but they're not asking about urinary incontinence, which is just important to a woman or man's quality of life. So we can do work on both ends of the patient-physician relationship.
The physician and the nurse practitioner and the PA should be asking.
100%.
Very good. Well, it's your territory, of course. Yeah.
I'm biased.
While the result is essentially the same, there are a number of causes for urinary incontinence.
I would say it's very, very common. So up to 50% of women have some sort of urinary incontinence and some level of it. So as we age, the likelihood of urinary incontinence is higher. Obesity is a risk factor, so as weight goes up, there's more risk as well. Having babies, of course, increase the risk. There's some argument of how much it matters if you have C-section or vaginal delivery, but vaginal delivery is thought to be a higher risk factor. If there's any family history of urinary incontinence, that would be a risk factor as well. Stress incontinence is when women have incontinence associated with increased pressure in the abdomen, so like with coughing, sneezing, jumping, that sort of thing. Very common in younger women, especially after childbirth. Urge incontinence is more so when a woman like all of a sudden feels like she has to go void immediately. And then mixed is if you have kind of both of those together, which isn't uncommon. And then the last type, the overflow incontinence, when there's leaking or dribbling with incomplete bladder emptying, or if the bladder is full, then there's incontinence there. Physical therapy is a really great option. There's pelvic physical therapy, so therapists who are specially trained in that field. That's the most helpful because it gets to the root of the problem and really treats the structural issue. Sometimes the muscles are too tight or not strong enough. And then there's medications directed at each different kind of incontinence that can be helpful. And then lastly, there's more aggressive options like surgery. So the diagnosis is primarily based on the history that the patient provides. Surely there's testing that can be done, and that's usually done by a specialist rather than us here in the primary care clinic, but we can diagnose it here based on the history that they give us. I think it's just important to know that it's very common and you're not alone, because it's kind of an embarrassing thing to talk about, so I think that's why people don't so much. And just to know that there are good, effective treatments, and not always a medication even, but therapy and things like that that can be helpful long term.
Thank you, Dr. Suni. This is your show. Your questions are key to our show discussion. So call in your questions about urinary incontinence or comments about urinary incontinence to 1-888-376-6225 or send us an email to ask@prairiedoc.org. So Dr. Suni is our new family physician at the Brookings Clinic, and it's a joy to have a chance to show her
She
strength.
made some good points.
She made some great points. So differentiating between causes of incontinence, what are they? Let's just go over the list. There's more than just stress and urge.
Those are risk factors, and I think, there are three types of incontinence that really we need to focus on. There's the stress incontinence. That's the leakage with activity, laughing, coughing, sneezing. And the root cause of that is damage to the muscles and the support to the urethra. And that damage to the muscles typically happens with childbirth or surgery. All right?
Okay.
And the other issue, or the other type of urinary incontinence, is urge incontinence. That's where someone cannot make it to the bathroom in time when they feel a sudden urgency, like they have to go, and they don't make it to the bathroom in time. All right?
The cause of that confuses me.
So it is a syndrome. We call it overactive bladder syndrome, meaning that we don't necessarily know the true cause of urge incontinence. And we'll also oftentimes call it overactive bladder. All right? And that can be multifactorial. It could be part of the damage to the nerves. It could be related to the muscles. It could be related to something inherently wrong in the receptors of the bladder, or other factors that we just don't know yet. And so we call it overactive bladder syndrome because it doesn't have a specific root cause.
All right. And I can only speak to after the chemotherapy that I've had and some neuropathy, or maybe some other reason. I don't know. But when I have to go, I need to get there. I mean,
and that could be a factor of
age.
Aging, but aging affects muscles. Aging affects nerves. And first I want to say, I'm glad you're doing well and you're healthy and you look great, because this is my favorite show, and my grandmother supported this show for many, many years.
She's no longer
with us, but she'd be very proud that I'm here today, and she'd be more thankful, and she's looking down from heaven that you're doing well. So I'm glad to see that. So
thank you. But there's no specific understanding really of why urge happens, and it happens in men and women.
Correct.
And as you get older, it equalizes.
Yep, and even for women who've have given birth or had children, the aging factor kind of negates that. So if a person's never had children before, they reach a certain age, they have similar incidence of urge incontinence. But I think what I deal with mainly throughout my day is seeing patients who have mixed incontinence. They might leak when they jump out of a car, or when they slip on the ice or a step, or they cough or sneeze. At the same time, they might be going to the bathroom frequently, as well as have a sense of urgency, and they can't get there in time.
So it's a combination.
Yeah, and so we call that mixed incontinence.
So that's the three.
Those are the three
major
main
three.
ones. And I think the fourth would be more of a functional incontinence, where people have some type of disability, whether it's a dementia or it's a physical disability that doesn't allow them to get to the bathroom in time.
Arthritis, wheelchair.
Yeah, wheelchair bound, or someone
can't quite. Yeah. They don't have the ability to get to the bathroom.
Correct.
Yeah. Well, and so that's a fourth. If you were going to take 60-year-old people across the board, or on average, would you say 80% is stress and 20% is urge, or there's a 50%?
Well, I think the majority of them have mixed incontinence.
Really?
For those, the 30% of women have some type of a urinary incontinence once they get to the age of 65. 30% of that is going to be overactive bladder. syndrome. You know, if you look at the incidence rate, but in terms of majority of them, I think the majority of them have mixed, because sometimes it's hard to delineate, did I leak because I coughed or sneezed, or a coughing spell can induce a spasm of the bladder, and that can be either a form of urge incontinence that's hard to delineate. And I think an important thing that your viewers can go out and do right now is just do a simple bladder diary. You can diagnose this yourself by recording what you're drinking for 3 days, how often you went to the bathroom, what was occurring when you couldn't make it to the bathroom, or when did you have a leakage. And those diaries can not only be diagnostic, meaning telling you what's going on, it might be therapeutic, where, oh, I shouldn't wait 4 hours before I use the restroom, or maybe I shouldn't have that third cup of coffee in the morning,
right.
Where you can add some behavioral management. And any one of your viewers can go and do that
and almost solve the problem by themselves.
Well, they're not going to solve the problem, not necessarily, but it might help. But it leads to them to kind of understand how bothersome it is. How is this affecting my quality of life? No one dies from incontinence. They die from, they feel like they could, because sometimes it's so embarrassing at times for people. But it is a quality of life problem for people, where treating it, improving it, can affect their overall well-being. And that's why we're here talking about this tonight. We're not preventing a cancer, we're not preventing heart disease.
Right.
We are improving how they live their life, 100%. Yep.
We've got some questions. We appreciate your question. Thank you. A caller from Sioux Falls asks, I had prostate cancer 12 years ago and had surgery to remove it. Now I have very poor feeling in my bladder. I'm very proactive about using the restroom frequently, but still have a few accidents per year. Is there anything that you would suggest doing? Now, I kind of thought about spending a little time on men's incontinence, and I want you to jump in here, but for the most part, it's prostate that's obstructing the urethra, and it could be enlargement that's totally benign because you're older, or it could be there's a cancer there, but obstruction. Now, if the obstruction lasts too long, the bladder distends too much, and the muscles that push the bladder down lose their punch. It's sort of like a balloon that's been blown too large for too long, and it loses its squeeze.
Not as strong.
So that's kind of what the story is on men. Would you add any?
Yeah, but I think in that situation there is probably an urgency or urge incontinence, and what you want to make sure anyone who's had any type of surgery is that they're emptying their bladder appropriately. So they might not be completely emptying and have a little bit of leakage throughout the day, or a constant leakage, or overflow incontinence where they're not making it to the bathroom. But in that situation, with the surgery and the aging factors, it's probably some urge incontinence where either some medical therapy might be beneficial. There are some type of male slings, but I'd have him talk to his urologist about starting with medical therapy. But the thing you want to rule out anytime anyone's had surgery or gotten older and not sure what's going on is you want to make sure there's not a urinary tract infection. Make sure they're emptying their bladder appropriately, meaning that they're getting the majority of their urine out.
Okay. So thank you for that call about prostate cancer and urinary incontinence as a result of the surgery. And of course, I think that's one of those things you just sort of live with, because it's better not to have the cancer than it is.
Well, yeah, and I think urologists have become very good at doing surgery for prostate and nerve-sparing surgery, where they're trying to maintain the nerve both for sexual function as well as urinary function.
A woman from Sioux Falls has a bladder infection every 6 months for 2 years. Are there any preventive techniques that you can suggest with this?
Yeah, so women are much more prone to developing recurrent urinary tract infections, and many of the symptoms that when women do develop a urinary tract infection, it could be incontinence, it could be urgency frequency, pain, fevers, and because of the anatomy, how the urethra is shorter in a woman, the urethra is closer to the vagina, which has bacteria that normally live in it, as well as near the function for bowel movements, and all those things can play a role for it. Most people who are menopausal develop low levels of estrogen. Those low levels of estrogen allow for abnormal bacteria to develop. So sometimes treating that with estrogen cream, sometimes putting them on prophylactic antibiotics, sometimes acidifying the urine with certain medications.
Vitamin C.
Vitamin C in higher doses. There are also some supplements that people can use that helps acidify the urine so the bacteria can't latch on. But it's a very frustrating thing for people to develop recurrent urinary tract infections. But there are some supplements and some topical as well as oral agents that can help prevent those infections.
I think there's way too little estrogen cream used, and that can be a big solution, but there's fear of using estrogen. So why don't you answer that, respond to my comment, and then do you have an answer there?
Well, I think everyone's afraid of estrogen, and if you look at estrogen over the years, it started off in the 30s as this magical elixir that's going to maintain this fountain of youth.
Everybody was on it.
And then everyone was using estrogen cream, and it can affect the uterus where it can allow abnormal cells to grow in the uterus to cause bleeding or even cancer. And so in the 70s, it kind of got this backlash. Well, then in the 80s, they studied estrogen thinking this is going to help prevent women from getting cardiovascular disease.
And bone weakness.
And in bone weakness, but the studies were biased. They thought women were healthier, but we just weren't studying women because our studies were studying men and not women, so we just assumed that women didn't get cardiovascular disease, and boy, were we wrong. And that led us to do some studies on hormone therapy, and when they did the studies on hormone therapy with progesterone, they saw a rise in a risk of breast cancer, risk of strokes, blood clots, heart attacks. So it became this very taboo subject. If you look at estrogen alone and using it in small doses, it will not affect the uterine lining, and it will not cause breast cancer if someone has no underlying cancer there and using it in those small doses.
Or heart disease.
And in those small doses, but it potentially can or it can cause blood clots. But you have to take it on an individual basis and having that discussion. So just kind of this blanket statement that it's all bad for you is not true.
And if you're using vaginal estrogen.
Using vaginal is the safest. Using oral estrogen or the patches are not going to help the genitourinary syndrome, meaning cutting back on infections or urgency, frequency, or vaginal dryness. It has to be used topically or in the vagina.
So what's the right topical dose of estrogen in the vagina for a woman, and is it available generically? And is it available over the counter?
No, I mean, there are different things you can use, from moisturizers to acidify the vagina, probiotics. There's estrogen creams, there's estrogen pills, and they're used about 2 to 3 times weekly, and it depends whether or not you have a uterus. There are some new pro-hormones called DHEA that can be utilized to help change the environment of the vagina, change the pH of the vagina. So there's a lot of options that women can do for that, but not every estrogen cream or pill is going to lead to your inevitable cancer diagnosis. That's not true.
No. A woman from Brookings asks, what role does estrogen replacement therapy have in reducing incontinence? And the answer is, it helps with incontinence.
Well, you got to take it as a caveat, all right? So when they looked at oral estrogen, meaning that take it by a pill or a patch, it didn't help at all. It did not help urinary incontinence at all. When they use it in the urethra or around the vagina, it might help cut down on some sense of urgency, but it's not going to treat or cure incontinence.
Okay.
But she brought up, that's a good question from Brookings.
Really good question, thank you for that. And I would ask this, I mean, this is one of my experiences, and I think medicine might be doing it wrong. Many people, as a geriatrician, caring for many people in the nursing home, women will develop a recurrent infection, and then they develop a symbiotic relationship with the infection, and they just live with it. If you treated every urine test of every woman in the nursing home, almost all of them are going to have an abnormal urine anyway, and you're going to be giving too much antibiotic, and then you develop a resistant organism that's living in that nursing home.
Yeah, you have to be really careful of asymptomatic bacteria. You know, a large percentage of women, especially as they get older.
What does that mean?
That means that they have bacteria in their bladder that's not causing them symptoms. And people who live in nursing homes, actually, whether or not they're in their own room or not, they all seem to colonize similar bacteria there, whether they're healthy or not. And it becomes very important to use antibiotics judiciously. This could turn into a whole show about recurrent urinary tract infections. Very controversial, but I think getting back to the urinary incontinence, that's why ruling out those types of infections, being judicious with the use of that.
When you say judicious, carefully. Don't use a lot of it.
Correct.
Only rarely, or less.
Well, you got to realize that, you know, a large percent of women will cure themselves on their own of their urinary tract infection.
Yeah.
If they're otherwise healthy, have a normal anatomy, by drinking fluids, and giving some time, they will actually clear it on their own.
And very quickly, my personal opinion is that vitamin C, 500 or 1,000, 4 times a day in a nursing home, I know the data doesn't seem to support it. My anecdotal experience is it makes a lot of difference. People don't have those recurrent problems. Yay or nay?
Yeah, it can help. The data's not strong, but yeah,
it's not strong.
You're not hurting them with that.
Bingo. With the proper therapy, many symptoms can be helped.
Many people think that as you age, urinary incontinence is a normal part of aging. Many people think that after you have children or go through childbirth. Some people, as far as men go, think, well, I've had a prostate surgery, I should expect to have urinary incontinence, and that's just not true. People often think, oh, I can just buy a pad or a diaper or something at Walmart or Hy-Vee or a store of some sort, and I don't really need to talk to my doctor about it. What are they going to do? However, your doctor can do a lot for you. The doctors can do a lot of medical things, but they can also refer you to physical therapy. Traditionally, physical therapists work with muscles, joints, and bones, and sometimes nerves, and we try to improve people's quality of life. Pelvic floor physical therapists do exactly that. We're just working in a very more personal, discrete region of the body. But as you can see here, I have both the female and the male pelvis here. This red or pink area are all muscles. And so your pelvis is full of muscles that affect your bladder function as well as bowel function. You're looking at the pelvic floor. And the pelvic floor, this is looking at your body as if you were looking between the legs, looking up. This is your spine coming up this direction. But looking here, this is all muscle as well as here. And so as far as difference between male and female, the musculature is fairly similar. A lot of times I hear people say, well, can't I just do Kegel exercises? Won't that just fix? I know what Kegel exercises are. I can just do them. And my answer to them would be, if you know for sure that your pelvic floor is weak and you know for sure that you're doing a Kegel exercise correct, then I suppose you could just do them on your own. Tension can also be carried in your pelvic floor. So if you came to me in physical therapy and you had urinary incontinence and I found that your pelvic floor was tight or tense and I told you to do Kegels, theoretically I could make your problem worse. When rather you should actually do some stretching exercises that we can teach in physical therapy. In addition to exercises for either stretching those tense pelvic floor muscles or strengthening those weak pelvic floor muscles, we can do manual hands-on therapy, which is much more intimate with a patient, but just like you can go and get a massage or something like that, we can address some of those hip musculature and other pelvic musculature with very specialized hands-on techniques in the clinic.
So that was very interesting. I mean, Kegels is so important, I think, but she's talked about sometimes the better you need to do stretching. Explain that a little bit more.
So if you think about the pelvic floor muscles, it's all part of your core muscles, meaning your hip muscles that bring in your legs in and out,
your gut,
your muscles of your stomach to contract, and your lower back muscles. And she brings up, it's not just contracting and relaxing the muscles, that sometimes women after childbirth, there can be some tonicity, meaning that the muscles are just contracted too hard that they don't know about, that's either causing them pain or urinary leakage, and doing some stretching and relaxation techniques through a physical therapist is key. But what I want to bring up, that she brings up a good point, is you want to see a physical therapist that has a specialty in this field. And there's certain ones that get specialized training, whether it's through the American Board of Physical Therapy or there's a company that helps provide some education and training. You want to make sure that they're certified, that you're getting appropriate and adequate care.
All right, and obviously Monica was. So
100%.
Thank you. Sioux Falls woman says that she has, and we've got a bunch of questions, so
Let's
we
get to
want to run quickly. Has stress incontinence since high school during doing tasks like jumping jacks. What do I do to treat this when the exercises have not worked?
Yeah, I think that becomes a little bit more challenging for young women who haven't had childbearing yet, gone through childbirth, or haven't started their families yet. But there are certain things, the muscle exercises, or sometimes for people who do a lot of high impact exercising, marathon runners, there's a over-the-counter insert that people can purchase.
What is it called?
It's a poise insert that they make that
Poise.
that fits like a tampon, and then it acts like a cage to provide support to the urethra. Or sometimes a physician or a nurse practitioner or PA can fit you with what's called a pessary to provide some internal support. Or another treatment option is surgery, especially for one of the few things that we do surgically with high success rates is anti-incontinence procedure, but they need to be evaluated to make sure there's not another muscle component.
But watch the TV and it will tell you that there's these pills. And as I've read recently, they have very minimal help and there's all the potential for risks.
Yeah, and I think there's not a pill for stress incontinence. That's a leakage when you run, jump, cough, sneeze, and this caller's problem there. What you're looking at is more of those medications for urgency and urge incontinence, where there's some difference in opinions of how successful some of these medicines are.
And then you turn off all of the parasympathetic nervous system, you get constipation and dry eyes and dry mouth and falling and confusion and, confusion.
Yes.
Sioux Falls woman says that she has had stress incontinence. Oh, woman from Brookings asks, is there anything you can do for incontinence if you have MS?
So MS is a huge problem when it relates to urinary issues because MS can cause goofy things. It's a goofy disease, all right? And it's very common.
I've not heard it called that, but it's an unusual disease.
It's a terrible disease, and I have family members that are stricken by it, and it's very debilitating, but there are wide spectrums of symptoms.
Right, goofy presentation.
Goofy presentation, and what I mean goofy by their bladder, meaning that some women can't pee at all. They have urinary retention who have MS, or some people are going to the bathroom all the time, or some people have both, or some people just have some urge incontinence. And so because they have a neurologic problem, we'll call it a neurogenic bladder. And that's the problem they have. But there are new therapies. Sometimes the medicines work for these patients, the antimuscarinics, where they block the spasms of the bladder.
Right.
Or we can use botulinum toxin, which is a muscle paralysis medication that we inject into the bladder that relaxes it. And we've had some good success for that for women to control the urinary incontinence. Spasms in the bladder or have urgency or frequency, specifically in the MS population.
Right. A female caller from Huron, I didn't say Huron, I said Huron, asks about interstitial cystitis.
Yeah, so interstitial cystitis is, I think a better term for that is bladder pain syndrome, meaning that they have pain when their bladder is full. And they feel better either emptying on the bladder or emptying their bladder or sitting on a toilet, or they have urgency, frequency, or pain, or they're waking up a lot at night. And
that's a tough
It's a tough disease, and it's often associated with other pain diseases such as endometriosis, which is a pain when during menstruation that women can suffer, or it might be associated with irritable bowel syndrome. And so there are certain things that we treat that where it's fairly similar to some of the medications we use for urge incontinence or some of the therapies we use for urge incontinence, but there are other dietary changes, medicines that we can put in the bladder that can help manage that bladder pain syndrome or IC.
Stretches?
So sometimes
exercises?
Sometimes physical therapy will help if they're having because a lot of times they're in so much pain that those muscles are just so tense that they can't relax, and learning to do those exercises that the physical therapist you had on the last video showed is doing some stretching exercises to relax those muscles, help the bladder pain go away with either medicines, muscle exercises, or I can put medicine in their bladder.
Just as a general internist, my thought would be get them exercising, like walking on a regular basis. Put a pad in, go for a walk, get going, get your mind off concentrating on your bladder.
Yeah, those pain. I mean, exercises helps everybody, the endorphins, especially for a pain syndrome like they have, to finding those things. But it's a very debilitating disease. But I think really changing diets and really focusing on other factors that trigger the pain syndrome is really helpful to individuals that suffer from that disease.
It was nice of you to not say you're wrong, Rick. But that's okay. Although I think that what happens is these people stay at home and they just sit there and all they have is their bladder pain and they concentrate on it. I'd say get out and get going.
You're being too easy, man. It is a debilitating condition. I see it, and it's a tough diagnosis. It's an uphill battle that has lots of ups and downs.
All right. A male from Rapid City states, when I have the urge to urinate but ignore the urge for a maximum of 15 minutes, I'll also have the sudden urge to defecate. And is there something that I can do for this?
he brings up a good point that the bowels and the bladder
they work together.
They work together, and they follow. You were talking about, you were using terms like parasympathetic and sympathetic, and for the lay viewers and my 8-year-old who's watching, that just refers to how the brain controls how our body works. And when it comes to urinating or having a bowel movement, they follow a similar neuropathic pathway, meaning how the nerves tell everything to do. And so with that, there are certain medications you can do, but I think it's just how things are wired, and trying to do more bowel issues to help kind of regulate the bowels, and then getting the bladder under control with medications, I think are helpful. But those are tough things. Where we see the more common problem is people who have urinary incontinence have a little bit higher rate of incontinence of stool or gas, which is we call anal incontinence or fecal incontinence.
Challenging issues. I mean, there it is. A woman from Castlewood asked, what is the trigger in the bladder that tells you that it's time to urinate?
So the way the brain works, and you know, for all the training I went to, it's the same amount of training as a neurosurgeon. And if you think about all the things that we do, the last thing that we can control, and having raised kids, is our ability to control our voiding. All right? You can rationalize and talk and tell jokes and write your name, but sometimes controlling your bladder is the last thing to kind of get going. So the way that works is there's a processing center in the brain that controls that whole process. And as we develop our comprehension and our frontal lobe, where we kind of decide, hey, now I'm on TV, now is not a good time for me to urinate, all right?
I've thought that off.
Yeah, well, that's an urgency, but overcoming that is where you can use the frontal lobe, and that's why some behavioral changes we didn't talk about, using the bladder diaries, or bladder retraining, teaching your bladder to go at certain times,
or biofeedback,
biofeedback
mechanisms.
Correct.
A woman from Brookings had the Sling procedure 4 or 5 years ago, but with the last 6 months been experiencing more incontinence. Would physical therapy help from having to do a second procedure? Very quickly, tell us the Sling procedure and how effective is it, and how long does it last?
So the Sling procedures are a outpatient procedure where we place a small piece of mesh underneath the urethra, in the middle of the urethra, to prevent the urethra from moving, so when they cough or sneeze, it actually kind of kinks off and they don't leak urine during activity. And it's about 85% effective at treating the leakage when women run, jump, laugh, cough, or sneeze, or stress incontinence.
But it's not an outside thing, it's inside.
So there's different approaches, there's different devices that they can utilize, or we can actually use women's own tissue, where we take a strip of muscle from their abdomen or from their leg, which is a little bit larger procedure, and that can help support the urethra as well. It might not be as long lasting, but if you look at the data on slings, the 80 to 85% hold up well past 10 years, so it's very effective. And what I think for this woman who has still having urinary incontinence, that might be that mixed incontinence. She had the sling, it worked great for running, coughing, sneezing. Now she has urge incontinence, or urgency frequency, and physical therapy can help with urgency frequency. It can help with mixed incontinence. It can help with stress incontinence. So I think she'd be
well served by going to PT.
But I think ruling out, figuring out what kind of incontinence she's having is key.
There's some lawsuits about slings. Very quickly, is it justified, or was it an old method that was harmful, or what about that?
So when they looked at all the data, they were using slings to treat stress incontinence. Very effective, safe, low risk, still allowed on the market. When they started using mesh for prolapse, they had started more severe complications. And when the FDA looked at all of this information, they said, hey, companies that make mesh to treat prolapse, that's when the bladder falls or the rectum falls, we'd like you to do some more studies and get some more information. And a lot of companies pull off some of their products. And when they looked at anti-incontinence procedures such as slings and the mesh slings, the FDA said, we're okay with those staying on the market as long as people know this is a permanent material, but we don't need any more data because the data is strong and very effective, and it's probably considered the first line therapy to treat surgical line stress incontinence for women.
Wow. A viewer from, I loved hearing that, because I've often thought about the lawsuits that people, you see lawyers advertising, if you've ever had a mesh put in for incontinence. So that's not it. It's mesh for prolapse.
That's not true, because they can, those lawsuits are both, but the courts are deciding that. But if you look at from FDA approval, and those are still available to help women, and they've been shown to be very effective with good long-term results.
And safe.
Correct.
A viewer from Facebook would like to know why patients have to go through so many appointments before getting urinary problems taken care of.
It's a quick question. So if someone came to me and they just leaked when they run, jump, laugh, cough, or sneeze, I want to assess them to make sure they don't have an infection, make sure they empty their bladder appropriately, and making sure I can demonstrate what bothers them. Then I offer them the different therapies. There's no other testing. There's no other appointments. It's when we're trying to weed out all these different urinary types. Do they have urge? Do they have stress?
Right.
Are there other factors involved? And it's not black and white, and those need some more testing so that people are educated and counseled enough that if they do have some therapy, okay, this is going to get better, this may or may not change, this could potentially get worse. So it informs of us and gives us enough information. And there's not one test that says, here's everything you need to know. Unfortunately, often many visits are required to understand things.
We got 50 seconds. A viewer, we're going to have to go afterwards and go to Facebook and answer the rest of this question. If a viewer would like the docs to describe Kegel exercises in more detail, I think we'll do that. We'll do that later. A viewer has a urinary tract infection, constantly, probably about 6-8 weeks or 2 months, takes antibiotics, and then it starts it all over. What can be done? More workup needs to be done, probably.
I think more workup, I think some prophylactic measures, but I think she probably needs to be on a longer course of antibiotics for prophylaxis.
One more question, 15 seconds. Male viewer states, I keep seeing television, magazine advertisement, incontinence pills all the time. Are they scams or are they validity? Are they valid? 5 seconds, incontinence pills.
Yes, there are pills that are very effective, but this is such a huge problem. There are a lot of sham products out there in the market, so be careful. Do ones that have been studied by the FDA.
Yeah. And now for the winner of tonight's Prairie Doc Quiz question. Choose the best answer. When urine leaks with a cough or sneeze, this is called A, urge, or B, stress incontinence. When the sudden need to urinate is so strong that the individual doesn't make it to the bathroom at the time, it's called A, urge, or B, stress incontinence. And the answer is B, stress during a sneeze, and A, urge when the need is so strong. It was Michael Chapman from Sioux Falls who answered the question correctly. Thank you, Michael, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Because you don't want to miss out on the little things. Because you want to be there for life's important milestones. There are many reasons to get life-saving cancer screenings. More than 4,000 women die each year from cervical cancer, but regular screenings can prevent this cancer and catch it early. Do it for the people you love.
Promise?
Promise.
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 Make the promise to get screened. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
Mrs. B started having a leaky bladder after her third child, notably whenever she laughed hard. The problem worsened as she grew older, and by the time she was in her 60s, she was wearing a pad purchased at the local pharmacy. Mrs. B finally came in to the doctor for help and asked about medicines that promised help for incontinence that she had seen advertised on TV and in magazines. The doctor referred her to physical therapy to help her learn pelvic muscle exercises, and after a second patient plea, also prescribed the medication requested. The patient didn't do the exercises, but took the medicine, which was quite expensive. Over the next 3 months, she noted maybe some improvement with leaky bladder, but she still needed pads, and she began experiencing problems. Side effects included constipation, dry eyes and mouth, blurry vision, insomnia, headaches, and depression. Also, she had recently fallen several times. This is not an uncommon story. About 1/3 of all women older than 60 years of age experience some level of urinary incontinence, and this is twice as often as in men. Incontinence in women is generally the result of previous pelvic surgery or childbirth or menopause. In men, it's generally the result of benign or malignant prostate growth blocking the urethra and bladder exit, which can cause an overexpanding of the bladder. If that dilation lasts for too long, this in turn can cause loss of bladder contracting strength and worsen the problem. In men, it's important to remove the blockage by either shrinking the prostate with medication or surgically opening the pathway before the bladder becomes overexpanded for too long. In women, the medications are much less helpful and have safety issues, especially in older women. The most important way to help women starts with pelvic floor muscle strengthening exercises, and the sooner the better. Also, there are bladder training techniques, pelvic surgeries, and even bladder stimulation devices that can help. Experts advise slow tightening and relaxing the pelvic floor muscles like 200 times a day, whenever you think of it. Make it a habit tightening the pelvis whenever you smile, and smile often. That would help women and men alike. Bottom line, especially in women, medications can only be of minor help, but carry with them dangerous side effects and cost. Pelvic floor muscle strengthening exercises are more effective than meds, without side effects, inexpensive, and underutilized. Do it with a smile so you can laugh without worry. Well, a great big thank you for our guest, Dr. Mathew Barker, for joining us in the Yeager Media Center studio in the campus of South Dakota State University. Go Jacks! His volunteering of time and travel are appreciated. We thought you might be interested in what all goes into making an episode of On Call with the Prairie Doc. Here's a quick look behind the scenes. By the time my guests and myself get onto this set, about 20 minutes before the show, a lot of people have spent a lot of time doing a lot of work. Weeks before the show, our production crew has met several times, done the interviews, created the graphics to tell our story. Thanks. Every Tuesday at 7:30, our production staff meets to go over what still needs to be done for that week's show, as well as looking to future shows' needs. Thursday morning, the producer Jay and I have a breakfast meeting at a local diner to go over the final tweaks of the show and script. The production crew arrives early to talk about the specifics of the night's show and put the set together. And playback videos are readied, the script is added to the teleprompter, and the graphics are checked one more time to be sure they're correct. Once our guests arrive, they're welcomed into our green room, get a cup of coffee, and are updated about the way the evening will progress. The guests are always gracious enough to answer questions about careers in medicine from our Prairie Doc assistants, or PDAs. These are a group of pre-med students who volunteer to help with various duties for the show. Most importantly, answering the phones when you call in your questions. Once the show begins, the energy of the studio and control room gets a sharp focus. Live television is an adrenaline high. So that's a quick look at some of the things that go on behind the scenes in every production of On Call with the Prairie Doc.
1 minute to air, Dr. Holm.
Well, it's time to go. Enjoy the show. Well, that does it for tonight. We will continue on Facebook from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people. And so,
is it pharmacy industry, the indecision in Washington, our desires to do whatever is necessary, or some combination? The exploding cost of health care. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen District Medical Society,
Black Hills Medical Society,
3rd District Medical Society, Brookings, Madison, and Flandreau,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.